السلام عليكم جميعا. اليوم today inshallah we will continue with our presentation on the radiological evaluation of endocrine bone diseases. And yesterday we stopped at the pseudohypoparathyroidism. So pseudohypoparathyroidism, they are a group of genetic disorders. They are characterized by features of hypothyroidism like hypocalcemia, hyperphosphatemia, increased parathyroid hormone. It is hypoparathyroidism, but there is increased parathyroid hormone due to the target organ unresponsiveness. The target organs, especially the kidneys and the bones, are not responding to the parathyroid hormone. They are not functioning according to the parathyroid hormone. So the parathyroid glands are working properly. They are excreting parathyroid hormone, but the end organs are not responsive to this hormone. So the result will be pathologically there will be features of hypoparathyroidism, but the parathyroid hormone is increased. So it is not a real hypoparathyroidism, it is pseudo hypoparathyroidism. Clinically, as features of hypoparathyroidism, there will be tetany, cataract, and nail dystrophy. The end organs are not responsive to the parathyroid hormones, but the parathyroid glands are normal and even increase parathyroid hormone excretion to make the end organs responsive. So, as we said, it's usually involving the bones and the kidneys, but there is a very rare variation of parathyroid of pseudohypoparathyroidism. In this pseudohypoparathyroidism, the kidneys are unresponsive, but the bones are responsive. Okay, the kidneys are not responsive, but the bones are responsive to the parathyroid hormone, which will be increased. So the result will be the kidneys act as if there is hypoparathyroidism, while the bone act as if there is hyperparathyroidism. And this condition is called pseudo-hypoparathyroidism. So the kidneys act like hypo and the bones act like hyperparathyroidism. Some of the clinical and radiological features of pseudohypoparathyroidism resembles those seen in other hereditary syndromes. So it's not that easy to differentiate whether this case is a pseudohypoparathyroidism or some other syndromes like Turner syndrome, acrodysostoses, Prader-Willi syndrome, fibrodysplasia ossificans progressiva, and multiple hereditary exostosis. These syndromes can have features similar to the pseudohypoparathyroidism. The radiological abnormalities at birth could not be seen. At birth, everything can be normal or looks normal. But later, the patients will develop premature epiphyseal effusion because it acts like hypoparathyroidism. So the epiphyses are closed prematurely, calvarial thickening, bone exostosis, calcifications in the basal ganglia and soft tissues. The metacarpals will be, here is a very important thing to notice, that the metacarpals of the hand will be shortened, especially the fourth and fifth. The fourth and fifth metacarpal will be shortened. This will result in what's called positive metacarpal sign. Normally, if you draw a line, okay, at the heads of the fifth and fourth metacarpals, it will not intersect the third metacarpal. The fifth and fourth, if we draw a line, it will not intersect the third. So when the fourth and fifth are shorter than normal, the line will intersect, and this indicates there is a positive metacarpal index. So this positive metacarpal index is not specific for pseudohypoparathyroidism. Other congenital abnormalities can have this feature, including Bickford-Friedman syndrome and basal cell nervous syndrome. Multiple epiphyseal dysplasia also can be seen in acquired conditions like juvenile chronic arthritis, sickle cell disease, and conditions of bone infarction. Soft tissue calcifications occur prominently in a plaque-like distribution in the subcutaneous areas. Rarely, the soft tissue ossification can occur in the periarticular distribution, periarticular, around the joints, involving the hands and feet. Something to make it even more complicated, there is something called pseudohypoparathyroidism. So we have hypoparathyroidism, pseudohypoparathyroidism, pseudohypohyperparathyroidism, and pseudohypoparathyroidism. So it's a little bit tricky and confusing. However, in the pseudohypoparathyroidism, features are the same as the pseudohypoparathyroidism, but there is no associated parathyroid or other biochemical abnormalities. So the radiological features, the morphological features, all are those of pseudohypoparathyroidism or hypoparathyroidism, but the parathyroid hormone is normal, the calcium is normal, the phosphate is normal, everything looks normal, but radiologically they are abnormal. So this is called pseudohypoparathyroidism. The abnormalities here will include metacarpal and metatarsal shortening, calvarial thickening, exostosis, soft tissue calcification, and ossifications. All of them are the features we talked about previously. Also, we can see some basal ganglia calcification in the brain. The bone density here may be normal, reduced, or increased. So, for example, let's see here. This is what we said. This is the positive metacarpal index. You can see the fifth and fourth metacarpals are short, and if you draw a line at the head of the metacarpals, just let me put the laser pointer. So if you draw a line at the heads of the metacarpals, it will intersect the third metacarpal, okay? And this is a positive metacarpal index. Also can be seen in Turner syndrome, Klinefelter syndrome, pseudohypoparathyroidism, and pseudohypoparathyroidism. Another example of metacarpal shortening can be seen here. You can see this metacarpal is very short, again the fourth and fifth. However, here due to the shortening of the third metacarpal, there is no positive metacarpal sign. Also here these metacarpals are obviously shortened. In this survey of a CT image, well, it's not very obvious, but clear that the third, fourth, and fifth metacarpals are all shortened, and this is classically described in pseudohypoparathyroidism. Again, you can see here, this is a 14-year-old patient with a pseudohypoparathyroidism showing extensive heterotopic ossifications and calcifications in the soft tissues of the foot, consistent or going with pseudohypoparathyroidism. The basal ganglia calcifications that we talked about, and also can be seen in very young age group, like in this case here, this is a 7-month age child with pseudohypoparathyroidism, and you can see the calcification in the scalp on the right side and reaching to the parietal bone. Plaque-like calcifications or soft tissue calcifications, we said they are rarely seen in the periarticular location and can be seen in the soft tissues. You can see here there is massive exuberant soft tissue calcification in the surrounding the right hip joint. And of course, you can see the bone thickening and the wavy form of periosteal reaction in the left femur, also obvious. Now, let's come to another very common endocrinological problem. That is the thyroid disease. Bone manifestations can be seen with over or under activity of the thyroid gland. So it can be seen in thyrotoxicosis, increased activity of thyroid gland, and myxedema, also decreased activity of the thyroid gland. So the thyroid disease in adults may cause osteoporosis, cause bone osteoporosis. In congenital form of hypothyroidism, or in childhood form of hypothyroidism, which is called cretinism, there is, due to hypothyroidism, the body will be like on slow motion. It will not progress as it's supposed to be. So this will result in reduced bone age, retarded skeletal maturation, fragmented epiphyses, they call it also slipper-shaped vertebrae, and Wormian bones, multiple Wormian bones in the scalp. There is something called thyroid acropatchy. Thyroid acropatchy is three things mixed together, three things present together. These are pretibial myxedema, exophthalmos or thyroid eye disease, and the clubbing of the fingers. So exophthalmos, clubbing of the fingers, and the pretibial myxedema are in combination called thyroid acropatchy. And radiologically, then we will see the physical periostitis involving the tubular bones of the hand. The bones of the hand, the metacarpals, especially in the phalanges, there will be the physical periostitis. There will be periosteal thickening that involves the soft tissue of the tubular bones of the hand. And the patient, not necessarily to be thyroid high or hyper or hypothyroid. It might be thyrotoxic, can be euthyroid, can be hyperthyroid, hypothyroid, or euthyroid. Okay? So, thyroid acropatchy tend to have a solid periosteal reaction that may be thin or thick. So the periosteal reaction is not like a Codman triangle, for example, or onion peel appearance or sunburst appearance. No, it is a solid periosteal reaction which can be thick or thin. Some radiologists call it wavy pattern. It's just like a wave. And we will see examples of that, multiple examples. Findings typically, since it's systemic disease, there will be bilateral involving the tubular bones of the hands and feet, as we said previously, and the reaction is mid-diaphyseal and symmetrical. Okay? So, what are the bones that are most commonly involved? First, we said the short tubular bones of the thumb, index, and little metacarpals. The thumb, index, and little metacarpals. Also the proximal and the middle phalanges of the same digits. So the proximal and middle phalanges of the thumb, index, and fifth fingers. And also the hallux or the big toe are involved. Thyroid acropathy can involve the long bones of the legs and forearms, although this is less common. The long bones of the legs and forearm can be involved, but less commonly. So let's see here. This is what we call a fluffy diaphyseal periosteal reaction. You can see this periosteum. This is not normal. This is more like a normal periosteum or close to normal, but this is a thick, solid, wavy type of periosteal reaction involving the phalanges, the proximal phalanges, a little bit less in the middle phalanges, and you can also see some in the metacarpals. And you can see here the clubbing of the finger, which is so obvious, and here you can see this solid periosteal reaction. These are two features. So the clubbing is a part of the thyroid acropathy. And again, another example, you can see here this type of periosteal reaction that we talked about. It is in the form of a linear periosteal reaction, solid, okay, involving the first, second, and fifth metacarpals. Also, findings can be seen in the phalanges. You can see this periosteal reaction here and there, okay? This periosteal reaction, this wavy kind of periosteal reaction, is almost always associated with benign process. It is not in the differential diagnosis of malignant bone periosteal reaction. You can see it in thyroid acropatchy, you can see it in hypertrophic osteoarthropathy and pachydermoperiostitis. So there is like a differential diagnosis for it. Let's see here, this is a case of thyroid acropatchy, and you can see the periosteal reaction, the thick, solid, wavy kind of periosteal reaction in the metatarsal bones here and here on the right side, and on the left side we said it is symmetrical since it's a systemic disease. Now, in cases of hypothyroidism, the growth will be retarded. The patient will not grow normally, okay? And this will result in stippled or irregular capital femoral epiphysis bilaterally. You can see this is irregular kind of epiphysis, capital femoral epiphysis. Now, enough with the thyroid gland, and let's move to the Cushing syndrome. Cushing syndrome, you have Cushing disease and Cushing syndrome. The Cushing disease is caused by pituitary adenoma excreting ACTH, causing increased cortisol excretion into the blood. While Cushing syndrome, it is due, the pituitary gland is normal. There is no pituitary adenoma. So the excess cortisol is being excreted either from tumor of the adrenal gland, like adenoma or carcinoma, or can be ectopic as part of paraneoplastic syndrome, for example, bronchial carcinoma, acting as a excreting ACTH, causing what's called paraneoplastic syndrome, or can be iatrogenic if we as doctors give glucocorticoids to the patient for any reason. So what are the cardinal skeletal manifestations? The main thing is osteoporosis. You see a relatively young patient with osteoporosis, which is weakening and increased fragility of the bones. It affects mainly the sites that are rich in trabecular bone. So the axial skeleton, the vertebrae, the ribs, these things will be more affected than the cortical bone, like in the limbs. Low trauma fractures. Patients fall from like half a meter, result in a fracture. This is a low trauma fracture, easily fractured bones. And when they heal by a big callus formation, exuberant callus formation. So these are the features: avascular necrosis, osteoporosis and low trauma fractures. Also, the patients will frequently develop avascular necrosis of the hip joint. Okay. Now, regarding Cushing syndrome, the cardinal manifestations, as we said, there are osteoporosis affecting the sites rich in trabecular bone. Low trauma fractures may be present that heal with exuberant callus formation and avascular necrosis of the hip joint. Here, everything for the first look looks okay. But if you look carefully at the pubic bones bilaterally, you can see that they are dense compared to the other bones, for example. And this is as part of osteoporosis secondary to Cushing syndrome. What do we see here? This is a relatively older age group patient. This is a 66-year-old patient, and you can see there is a compression fracture of the L1 vertebra. It's complete loss of height, and this is due to the loss of bone trabeculae, which is osteoporosis, and you can estimate the presence of diffuse decreased bone density or diffuse osteoporosis. Again, here there is a low trauma fracture of the left femoral intertrochanteric fracture. This is as a result of osteoporosis causing low trauma fracture. You can see here also another fracture at the inferior pubic ramus and superior pubic ramus with some big callus formation around the fracture site. You can see here another fracture of the, this impacted the fracture of the distal left radius due to the osteoporosis. Low energy can cause fractures of the already abnormal bone, already weak bone. And as we said, avascular necrosis is very common here. And you can see in the this left femoral head, it is hypodense and it is irregular, and some cortical irregularity seen with mild loss of height, indicating avascular necrosis secondary to Cushing syndrome. In this MRI, you can see the bone here is obviously abnormal at the femoral head, at the left femoral head, associated with some surrounding edema and irregularity indicating avascular necrosis of the femoral head. And we can have bilateral avascular necrosis, and they can be of the same age group at the same time or different from at different times from each other. For example, you can see here, this is avascular necrosis of the right femoral head, and again the same thing on the left side, but they are of different ages. So it is a long-standing condition. One of the things of endocrine bone abnormalities that I personally found easy to look for and to diagnose are the features of acromegaly, which is due to excessive growth hormone production resulting as a result of a pituitary microadenoma. Pituitary microadenoma increase growth hormone excretion, resulting in accelerated growth. So you will have either acromegaly or gigantism. If the pituitary microadenoma is in children before the epiphyseal closure, before the bone stops growing, then it will be a gigantism, which is like a really, really big person. The patient is like over 2 meters in length, while if it occurs after closure of the growth plates, there will be acromegaly. The features will be more coarse facial patterns. We will see some examples now. So what are the radiological features? We have in the skull, there will be calvarial thickening, enlarged sinuses called pneumosinus dilatans, and big cellular torsica due to the pituitary microadenoma, and prognathic jaw, prognathism. The jaw will be bulging anteriorly, protruding anteriorly. In the hands, the terminal phalanges will have a spade-like appearance. We will see some example. There will be widening of the terminal phalanges. The joint spaces can be also enlarged due to thick articular cartilage, and there will be, as a result, premature osteoarthritis in later age. The heel pad thickness of the foot will be increased, and if you do pituitary gland MRI and you can see the microadenoma that is relatively diagnostic and straightforward, you can use dynamic contrast enhanced MRI to increase the sensitivity of detection of the microadenoma, which will appear as a hypoenhancing lesion compared to the rest of the pituitary gland. So here we can see the pituitary gland or the sella torsica to be enlarged. Okay, the sella torsica is big and enlarging, and you can see the big jaw prognathism, it's bulging anteriorly. You can see the pneumosinus dilatans. These are very big paranasal sinuses, especially the frontal sinus. This is a lateral view, and these are consistent with acromegaly. Also what's called hyperosdosis frontalis interna. You can see this frontal bone is abnormally thick and big due to excessive growth hormone formation. This is called hyperostosis frontalis interna. Another example of skull with excessive growth hormone is this skull. You can see the pituitary gland. It's big, okay, and widened, and you can see the big frontal sinus here, okay, and you can see the jaw is, it's cut a little bit from the image, but there is prognathism, definitely. Regarding the hands, we said the findings in the hands are expansion of the distal phalanges, what we call spade-like phalanges, okay, and you can obviously see here the distal phalanges are widened and spade-like. Spade means something that you row a boat in, okay? So these are like the spade-like pattern, while if you look at the heads of the metacarpals, they are relatively normal. There is nothing here. You can see some bulging and osteophytes from here and there with a spade-like terminal phalanges, and you can see the soft tissues are thick and prominent, all indicative of acromegaly. Another example of the hands findings, you can see it here. These are the spade-like terminal phalanges, and you can see what's called, some of them shows a hook-like metacarpal hooks at the metacarpal bones. You can see this is like a hook, which is also findings we see in acromegaly, hook-like osteophytes of the metacarpal heads. Magnified view showing the spade-like pattern, and you can see there is a widening of the joint space here due to thick or big articular cartilages. The heel pad thickness is the measurement of the soft tissue from the most inferior part of the calcaneus to the skin on a lateral foot X-ray. There is a normal values for male and female. We can accept in general 21 millimeter to be the maximum accepted length. If it is more than 21 millimeter, then this is abnormal and can be indicative of growth hormone abnormality or acromegaly. Also can be seen in other conditions like infection, local infection here will be result in swelling and increased heel pad thickness and generalized edema, and also obesity can change the heel pad thickness. We have an example here of an increased heel pad thickness. You can see it's very large amount of soft tissue here, indicating possible acromegaly. Another example of skull abnormality can be seen here. You can see the cellular torsica has what's called double flooring, 2 floors, due to the expansion by the pituitary adenoma, and you can see the pneumosinus dilatans of the frontal bone and the obvious prognathism of the jaw. Okay. Also in the lumbar spine, we can see some findings, including this is 21-year-old patient with acromegaly. The intervertebral disc space is enlarged, is increased due to the excessive cartilaginous tissue formation. And you can see some posterior vertebral scalloping also can be seen in this condition, mild form. Also, the pedicles can be of increased length. The pedicles here are abnormally long, okay? And there is a slight increase of the intervertebral disc space of this 65-year-old patient. You expect the discs to be narrowed, not at least normal or increased, okay? So when they are normal or increased, there is something wrong here. The excessive osteophytes formation, especially in the dorsal spine, can be seen in the form of calcification along the lateral aspect of the dorsal discs. In this 40-year-old patient with laminated calcification and ossification here, it is consistent with DISH, with diffuse idiopathic skeletal hyperostosis, but this patient had an acromegaly. We said the posterior scalloping is a feature of acromegaly. You can see the posterior scalloping here and here of the vertebral bodies. And this will be the end of our talk on the radiological evaluation of endocrine bone disease. I hope that you had a very good experience with that, and I hope that we can do the same thing again. Some of you asked if I can put the first slide again. Just a second.